What are the risk factors for obesity? Are there genetic factors? Are there environmental factors?
If you were to ask me my personal opinion, I can tell you it's food availability. You can't go anywhere in the United States without having food immediately available. It's easier to go to the nearest fast food place. Let's just face it, nobody wants to eat 3 times a day. Nobody wants to eat 2 times a day. We want to eat as soon as the stomach rumbles and as soon as we feel like we want to be happy again.
What happens if we don't get the obesity under control?
Obesity tends to cause death approximately 20 to 30 years earlier.
Welcome everybody, this is Dr. Valentin here at Houston Metropolitan Medical. Today is a very special episode as we kick off a new segment of the channel called The Consult. And we're basically welcome a specialist to discuss specific medical problems in their respective fields of expertise. And today we have with us Dr. Alian Garay. How are you doing, Dr. Garay?
I'm doing fantastic. Thank you for having me.
No, thank you for coming to join us. So some background on Dr. Garay. Okay, he's a fellow of the American College of Surgeons and is a board-certified general surgeon with a fellowship training in advanced laparoscopic, minimally invasive, and bariatric surgery. He's a member of the American Society of Metabolic and Bariatric Surgery, as well as the Society of American Gastrointestinal and Endoscopic Surgeons. All right. So tell us a little bit about what you do, what you work with.
Sure. So, I did medical school here in Houston, and then I went and did my surgical residency in Denver, Colorado at the University of Colorado. And after that, I went to Portland, Oregon, and that's where I did my fellowship in bariatric and minimally invasive surgery. I was very lucky, in my opinion, to get into the program that I got into because it was a broad program that focused heavily on bariatrics, but also on all aspects of advanced minimally invasive surgery. And I wanted to stay in the Intermountain West for a while. I like hunting and hiking and stuff like that. So I ended up moving to Idaho for about 6 years. And then after that, came back to Houston, which is pretty much where I've lived all my life, and established practice out here. And it's been very great. It's been successful. Been doing a lot of bariatrics. And I also do quite a bit of general surgery and stuff like that.
Well, yeah, that's specifically why we invited Dr. Garay today. Obviously, there's high prevalence of obesity in the country. There's like 40% since 2023. So that's why we're here today. We want to talk about obesity, what options we have to help treat it, and if needed, do we need surgery? So I wanted to start off with, so what is obesity and how can somebody know if they're obese?
Sure. So obesity is defined. The government has actually set standards for obesity. And right now, despite a lot of controversy, obesity is defined using the body mass index, which is a ratio of the person's height to their weight. And it uses this complex calculation, and ultimately you end up downloading an app and putting your height and your weight in, and it spits out your body mass index or your BMI. Right now, you're overweight. Okay, if your body mass index is above 25, 28, you're considered obesity. You're in the realms of obesity at 30, BMI of 30. You're class 1 obese at 30. If you get to a BMI of 35, you're class 2 obese. And if you get to a BMI of 40, then you're class 3 obese, which is morbid obesity. And with that classification of obesity, now you can get comorbid or medical problems that arise from being obese at any stage of obesity, but with morbid obesity, that prevalence tends to go up higher, and so that's why it's known as morbid obesity. And of course, the higher you get above 40, the more prevalence there is for these medical problems.
So what are the risk factors for obesity, and are there genetic factors? Are there environmental factors that can predispose us to this?
Yeah, sure, and the answer to that is yes. And to all of those. So we know there's genetic factors involved because, like, for example, if you take twins, right, genetically identical twins, they both tend to grow up looking genetically identical. And so if they're both overweight or obese, then they're both going to be overweight or obese unless they make significant lifestyle changes in their mind that really affect their lifestyle. So we know there's a genetic component, but without question, the biggest component, especially in the United States, is going to be environmental components. It's difficult to really pinpoint the environmental component that causes obesity in the United States. However, there's been a lot of studies done on this, and if you were to ask me my personal opinion, I can tell you it's food availability. Ultimately, it's food availability. You can't go anywhere in the United States without having food immediately available. In the 40s and 50s and maybe even the early 60s, if you wanted to eat, you had to wait until somebody cooked. And today, if you want to eat, nobody needs to cook. In fact, nobody wants to cook. It's just easier to order out. It's easier to go to the nearest fast food place. It's easier to drop something in the microwave. You can have food ready and available within 1 or 2 minutes whenever you want it. And that availability of food is because, let's just face it, nobody wants to eat 3 times a day. Nobody wants to eat 2 times a day. We want to eat as soon as the stomach rumbles and as soon as we feel like we want to be happy again.
We mentioned earlier that there were some comorbidities associated with obesity. So wanted to ask, what are some of the comorbidities that we could develop, from being obese?
Sure. And, so I have a clinic and we talk fat in my clinic all day long, right? Fat, because saying obesity, that's a 3-syllable word and fat is a 1-syllable word. And so we talk fat all day in our clinic. And so when you're fat, it's like every single patient that walks into my clinic with obesity, we know what their comorbidity is going to be because they're almost all identical. They have high cholesterol, they have high blood pressure, they have diabetes or insulin resistance. And those 3 things together is what causes what's known as the metabolic syndrome. And so the metabolic syndrome is then the things that lead to the other comorbid conditions that are associated with obesity, such as heart disease and clogged arteries in your legs and strokes and all of these other problems that are then related to obesity. But that's not the only thing, right? Obesity also leads to hormone imbalances. These hormone imbalances in people, especially in women, can lead to polycystic ovarian syndrome and things like that. In men, it leads to high-pitched voices, decreased size of the gonads and things like that because of high estrogen levels. People used to think that fat cells used to just sit there and just be fat and merry. But in fact, fat cells are metabolically active. And so they do all kinds of things, including convert hormones from one hormone to another and things like that. So when you have a lot of fat cells, your hormones are out of whack.
Yes. I've seen a lot of, but I've seen all of that. Okay. I've seen also patients with, like you mentioned, blood clots. I've seen also patients with ulcers from being, obese.
Cancer,
increased cancer, and sleep apnea.
And sleep apnea. Cancer is caused by those hormonal imbalances. And so women should be aware of the fact that too much estrogen can lead to, without progesterone, counteracting it can lead to uterine cancer and breast cancer. And so those are 2 big cancers. And in men, these hormone imbalances can lead to colon cancer. They haven't actually discovered why obese people tend to get more colon cancer yet, but it's pretty certain that they do.
So in terms of prognosis, so in terms of what happens if we don't get the obesity under control, what are we expecting? Like what is in terms of mortality?
Sure. Well, with regards to mortality, the first thing that you can expect is a significant reduction in the span of your life, an increase in mortality. And then, of course, when we talk about obesity, we talk about morbidity and we talk about mortality. And morbidity is all of the problems that can lead to death but don't lead to death. So, for example, stroke, heart attack, clogged arteries, decreased mobility. And those are just the medical aspects of it. But, the taboo portion of obesity is the things that nobody wants to talk about, which are the societal issues related to obesity. Things like not being able to get a job, being construed as someone who's lazy and incapable of achieving any types of goals, someone who is dirty or doesn't shower, things like that, things that are obviously not true, but the stigma of obesity is there. And then because of those comorbid problems lead the early mortality, which is the early death. I would say that obesity tends to cause death approximately 20 to 30 years earlier than you would expect for the average life expectancy. That's a significant reduction in life.
Okay. So, obviously we don't, once we're obese, we definitely, I'm sure we do, we recommend things to do. But what can we do? What would we recommend medically in terms of lifestyle changes for somebody that's obese or even somebody that's overweight to help them not get, obese?
Sure. So first of all, let me just say that when you become obese, the body wants to stay obese. And so it actually fluctuates your hormones in order to prevent you from losing weight, which is just a horrible thing, right? You have these hormones, ghrelin and leptin and things like that. These are hormones that regulate how much you eat and how often you eat, when you feel hungry, things like that. And when you're obese, you make more ghrelin and you make less leptin. And these are things that cause you to stay obese. So lifestyle modification with regards to obesity is really about doing more exercise. But remember that exercise is a fantastic tool for increasing muscle mass and improving your cardiovascular capabilities. However, when it comes to losing weight, exercise has very little impact on that. Anyone who's run on a treadmill for 30 minutes is always disappointed when they look down at the treadmill and see that they burned 142 calories, which is about a quarter of a slice of cheesecake. And so that's just not going to have a significant impact on your obesity. And so really it's about reduction in how much oral intake you take. And typically that'll mean going hungry. And then as far as medical options, of course, there's pills that you can take that can help with weight loss and medications that are recently available. And then there's the surgical options.
Yes. In terms of the pharmacological ones, I've used them on my patients as well. I've used, phentermine, Casemia. We started using the older GLP-1s like Saxenda, liraglutide, and now we have the Ozempics and the Zepbound, which they do provide significant weight loss. But I've researched the studies, once we stop them, we basically gain the weight back again. What is our next step? How do we, with surgery, help us lose weight?
Sure. And so I think that those medications have their place. And I personally, the only thing that I would say different from what you said is that I don't think they cause significant weight loss. I think they lead to weight loss. There's no question. So I think that if you have someone that needs to lose 30 pounds or 40 pounds, I think that those medications are good. I don't think someone who needs to lose 30 or 40 pounds needs to go and have bariatric surgery. I think that those medications are probably their best option. Bariatric surgery is really for patients who have tried other means of losing weight and just have not been successful, which is really the majority of us. And that includes you and I, both. Okay. I struggle to lose weight. I work out every day. I try to eat less. It's hard. So for patients who have morbid obesity and are looking at a significant reduction in their life expectancy, really their next step is to consider surgical options. For surgical options, there are multiple options, but ultimately they fall under two different categories. The first one is restrictive options, which decrease how much you're able to take orally. Mm-hmm. And then you have malabsorptive options that decrease how much you're able to absorb of the stuff that you take orally. Usually they combine those options so that you get restriction and malabsorption. But which one of those is really a conversation for you and your bariatric surgeon. But we can discuss those in detail as well.
So are there any contraindications? Because I'm pretty sure, some patients have tried, lifestyle changes, medical changes, and are really considering bariatric surgery. Are there any contraindications to this?
To bariatric surgery? Yeah. So, first of all, you have to take into consideration that it requires a laparoscopic operation. And laparoscopic operation means that your abdomen can't be hostile to laparoscopic operations. And so if you've had multiple previous open operations, such as big open hernia repairs, exploratory laparotomies for gunshot wounds and things like that, that can be a huge impediment to safely being able to go in and do a bariatric operation. Age is another factor, and health status. And so typically our cutoff age is about 70 for most patients. However, if you're 70 and very healthy, 71, 72 and very healthy, other than the weight, that you can be considered for bariatric surgery, but typically that's about the maximum. And then you got to be healthy enough to undergo surgery, and your risk factors have to be at least medium to low. So for example, someone who's had 5 previous blood clots, multiple heart attacks, are continuing to have chest pain and under the care of a cardiologist, typically those patients are going to be really high risk. Whereas patients who have had a heart attack in the past, but now they have a stent, they don't get chest pain anymore, but they're concerned about having future heart disease because of their weight, that patient is a good candidate. And so really it's a conversation between you and your bariatric surgeon, as well as you and your primary care doctor or your cardiologist.
In order to qualify or to have an indication for bariatric surgery, what is in terms of, BMI and comorbidities, like when should you say okay, this patient definitely qualifies for this?
So I think in general, patients with a BMI, body mass index of 35 who have medical problems such as high blood pressure, diabetes, or any combination of these things are good candidates for bariatric surgery. And then anyone with a BMI of 40 or above is a good candidate for bariatric surgery with or without medical problems associated with obesity. But it also depends on your insurance, because some insurances have dropped that requirement to 30 and 35 rather than 35 and 40 and things like that. And then there are patients who are looking more towards wanting to have bariatric surgery because even though their BMI is 32 or 31, those patients typically will not qualify from an insurance standpoint, but have cash pay options.
So let's say that somebody's met their criteria and we're good to go ahead with bariatric surgery. How do we prepare these patients before the procedure?
So the patients actually go through a pretty exhaustive workup process. First, they come in and they see me as the surgeon. They have to watch a 1 hour long video because we don't want the patients to just, we don't want to bring them in and just do bariatric surgery on them. We want them to learn heavily about what they're going to get themselves into, what is going to be required of them, and what their outcomes are going to be, what the risks are, things like that. And so they watch a 1 hour long video and then they move on to see me. After they see me, they have to visit with a nutritionist, usually between 3 and 6 times once a month. They have to visit with a physical therapist at least once in order to break through any barriers that they have with exercise. And they have to visit with a psychologist to make sure they don't have any psychological impediments to having bariatric surgery. Once they've completed all of that, then they come back and they see me. And again, we have to discuss which operation is best for them. I have to do an endoscopy on them, and we have to do a full set of labs on them. And once we determine which operation is best for them, we're going to discuss that operation. They're going to learn everything they need to know about that operation, and then we set up surgery. So typically it's between a 3 to 6 or 8 month process.
And that's great, because I think that you're giving them the best chance of success
That's right.
with everything. Because they need to get accustomed to what their life is going to be, moving forward from that.
And how to be successful, which is the most important, because what people don't understand is that when you restrict how much you're capable of eating, it's easy to lose fat, but it's also easy to lose muscle. And if you lose muscle while you're losing the fat will come back. So your goal is to maintain your muscle mass while you're losing the weight. And that means getting the protein that's necessary and doing the weight training that's necessary. Good news is I don't need you running. I don't need you huffing and puffing. I don't need you sweating in Houston. Everything that you have to do to maintain your muscle mass can be done in an air-conditioned room with some light dumbbells.
That's good to know. Good to know. All right. So you touched on that right now. So how would you select in general, what option would be best for what patient?
Sure. And this is a really important conversation. So I would say that in today's day and age, most patients want to have a sleeve gastrectomy. Okay. That operation is sort of an autopilot operation that comes with the least amount of risk and the least amount of problems for a patient. And what I mean by problem is that it's not malabsorptive. They don't have to worry too much about nutritional supplementation and things like that. But The problem with the sleeve is that it can worsen reflux. And so if a patient already suffers from really bad reflux, a sleeve may not be the best option for them because the reflux can get so bad, may not be treatable with medication anymore. And then the only way to cure the reflux is to either do a LINX procedure or convert them to a Roux-en-Y Gastric Bypass. I would say for patients who already have reflux, a Roux-en-Y Gastric Bypass is going to be their best option. The Roux-en-Y Gastric Bypass patients are typically my happiest patients because that operation carries with it the least amount of nausea post-operatively. They're able to tolerate food more quickly and things like that. But that operation comes with a little bit more luggage because that operation requires more nutritional supplementation because it's a restrictive and malabsorptive procedure. The band is really not done very much anymore. No one really does bands. It's gone by the wayside, and you'll be hard-pressed to find a surgeon who's willing to put a band in today's day and age. And then the other big malabsorptive operations like the biliopancreatic diversion and the duodenal switch, I personally don't do those operations, not because I can't do them. I've done them before. The issue is that there's such a significant malabsorptive operation that it can lead to maladaptive eating behaviors because the patient can continue eating heavily, and because they can't digest and absorb their nutrition, they don't gain weight and in fact continue to lose weight, but then they suffer from significant diarrhea, and it can lead to a lot of nutritional depletion. And so for those reasons, I prefer not doing those operations. And then there's all these new boutique operations that people ask me about, like stomach plications from the inside endoscopically, the balloon and things like that. The truth of the matter is that those operations are simple to learn and simple to do, but they carry with them a lot of problems, a lot of nausea, a lot of uncertainty. The plications can become undone very easily. The balloons migrate, and then the balloons can only stay in for 3 months, and then they got to come out. And when they come out, you got to spend a ton of money to put another balloon in. And I just don't see the benefit of doing something like that when you're going to do a stapling procedure and have a long-term outcome.
Okay.
But those are options that are available.
Obviously, we're talking about the patients that are considering this. What sort of complications could we possibly have, with these surgeries, because we have to be informed?
Sure. The biggest complication that people can have from this operation is a blood clot. That's the number one cause of death after this operation. I can tell you that in my 20 years of experience in doing bariatric surgery, I've probably had 2 blood clots, and no one has died from a blood clot. In fact, no one has died from any of the bariatric operations I've done, and I'll knock on something here. Those are the biggest risks. Other risks are ulcers in the stomach, and that means never smoking, no hookahs, no marijuana, no smoking banana peels, no smoking nothing after bariatric surgery, and also very much careful with nonsteroidal anti-inflammatory drugs like Aleve and ibuprofen and things like that. That doesn't mean you can never take them. You just have to be very, very moderate in how you're taking them because they can lead to ulcers. And then, of course, immediately after the surgery, you make connections and staple lines, and those can leak, and those can be quite detrimental. But all of those things are typically fixable and don't lead to death or anything like that. I've never had a leak, and I appreciate that as well.
And so despite the indication and the availability of these procedures that can help patients with obesity and its comorbidities, the lack of the insurance coverage for appropriately qualified patients remains a significant challenge to access the appropriate treatments. So do you expect this to change in the future?
That's difficult to say because we're moving towards, in my personal opinion, we're moving towards nationalizing healthcare. I think that as Social Security begins to really run out over time, because over time it will run out. Hopefully it won't be in our lifetime, but at some point it will. There's going to be a lot of talk about nationalizing healthcare. And right now, if you're employed and your employer gets health insurance for its employees, that employer gets to choose whether it wants to add bariatric benefits. And typically, if your employer has not added bariatric benefits, it's because there's never been a demand for it from their facility. And so I urge patients all the time to go to their HR department and say, hey, our insurance doesn't cover bariatrics. How do we get this added to our insurance? And believe it or not, your employer doesn't have to spend hardly almost any extra money to add bariatric benefits to your policy. However, when it comes to government insurance, such as the marketplace insurance, or known as the Obamacare insurances, none of those policies cover bariatrics. And I anticipate that when it comes to nationalized or government-led healthcare, they're not going to include bariatric benefits. And so I'm not sure that it's going to get better, but I do urge people that are employed and get their insurance through their HR department to talk to them about getting bariatric benefits if they don't already have it.
All right. So to wrap up, where do you envision bariatric surgery is heading with the indications for metabolic improvements?
So I think there's going to be a place for medical treatment. Like I think the GLP-1s right now are just the very beginning of medical management for bariatrics. And I think that realm is going to improve. And I do think that it's going to get better. And I think that they're going to discover ways to really treat obesity medically. However, I don't think that medication anytime in the very near future, and I'm talking about in the next 50 years or such, is going to be a cure for significant obesity, for morbid obesity. Right now, the GLP-1s, if you got on a GLP-1, you can expect to lose anywhere from 20 to 40 pounds maximum. Most patients losing about 32 pounds at maximum. That's just not going to be enough when you've got 150 pounds to lose. And so there's always going to be a demand for bariatrics, for bariatric surgery. And I don't think that that's going to decrease in the near future. However, I do think that what is going to decrease are the patients who are needing to lose 70 pounds and want bariatric surgery, but have the option of medical management and maybe not lose 70, but they'll be happy if they lose 40. And I think that that's going to cause a significant reduction in the amount of bariatric surgery that does get done in the United States. But it's going to have its place with the more heavier patients for sure.
All right. All right. Well, thank you so much, Dr. Garay, for coming in to join us today and talk about obesity and the treatment that we have available for us. So what is the name of your clinic, and how can patients reach out to you with any other questions or concerns, and if they're interested in pursuing these type of procedures? Absolutely.
So our clinic is here in Kingwood. It's Bariatric and General Surgery of Kingwood. We do bariatrics and, of course, everything general surgery as well. Our clinic phone number is 281-825-5100. You can just call our clinic and come in and watch our video. I think that what's helpful about our video is that it doesn't lie to you. It just gives you the good, the bad, and the ugly. And you may walk out and go, there's no way I'm doing this. Or you may walk out and say, I want to do this, but I'm just not ready for this right now. Or you may walk out and say, you know what, I'm ready for this. I need this more than ever. And but you're not going to know that unless you watch our video. And you can go on our website as well, which is www.bariatricsofkingwood.com. And our videos are there as well. And you can call our clinic and we can help guide you into getting into those videos. So we have gone over what obesity is. We have gone over the comorbidities that obesity can lead to. We have gone over pharmacological management, lifestyle management, and bariatric surgery options that we have. If you've liked this video, please like, share, and subscribe, and turn on your notifications to keep up to date with our most recent videos. Thank you, and until next time.